Great, thank you so much. I'm just so honored to be here on this panel, and I think this is incredibly important, and I'm just so impressed with the way that SAGES really embraces a lot of this. So I think you're gonna start to see some themes in my comments, and I'm gonna try to tie in what I say to some of the things that the previous speakers have already commented on. I do have one disclosure. I serve as president of the Academy for Surgical Coaching. This is a nonprofit organization, and we do receive funding from Johnson & Johnson, Intuitive, and Hologic. So as a department chair, my job really is to help my faculty and our department to advance all three of our missions, right? Research, education, and clinical care. And when you think about these missions, we've traditionally really thought of them as very different and very siloed and having different initiatives that address each of them. One of the really cool things I think about the concept of routine video recording is it is one of the few things I can think of that can really advance all three of the missions and can actually help to bring them closer so that the activities that we're doing by routine video recording can help to advance clinical care, education, and research, and can help us to use the same activities in a more efficient way to advance all three of those missions. So if we think about clinical care first, the greatest opportunity to improve surgical care is in the OR. And we already saw this, this statistic that 50 to 65% of adverse events are surgical if we take sort of all adverse events in healthcare, and about 75% of those occur in the operating room. So really understanding what happens in the OR is essential if we want to improve patient safety and the quality of care that we deliver. And when we think about when things go wrong and when there's an error, we like to think that it's somebody who's doing something they shouldn't be doing. But this study that we did when I was in Boston shows that when technical errors occur, 84% of the time, so the first bar, it's during a routine operation. So it's a lap chole, it's not a Whipple. And the blue bars represent experienced attendings operating within their specialty. So as you can see, the majority of the time when there's an error that happens, it's an experienced attending doing something they do every day that's routine where something goes wrong. And so as we've tried to understand how those things happened, I think Oliver had a version of this slide. We focused a lot traditionally on data that we have from different sources, right? So what is the risk that the patient brings? So the baseline operative risk profile, which includes things about the patient. It can also include things about the surgeon, what is their volume, those types of things that influence risk as you're coming into the OR. And then we look at patient outcomes or how the patient does afterwards. But we really haven't paid a lot of attention to or don't have a lot of data or a lot of understanding about what increases resilience or vulnerability to those adverse events when the patient's in the OR. And we can think about team performance, we can think about individual provider performance, and then we can think about system performance. And video offers us a unique opportunity to really study and figure out how each of these influences how our patients do and help us to identify areas where we could intervene and improve the care that we provide. So Oliver already showed us this study, which most people I'm sure in this room are familiar with, but there's been a plethora of studies that have come out after this, again, showing that as we start to understand how we can rate each other's technical skill, it strongly correlates with outcomes. And this is an important study that came out of the group in Illinois, where they looked at what types of outcomes were most closely related to surgical skill. And as you can see in the top right-hand corner, skill-related composite outcomes, so things that you would expect to be related to skill like reoperation or a complication directly, technical complication, were strongly correlated with technical skill. But skill unrelated complications or composite scores such as surgical site infections were not correlated with technical skill. So it helps to sort of reinforce the framework that underlies this that says that what we do influences how our patients do. The really cool study I thought that came out of this was actually looking at the longer-term survival of cancer patients and showing again that the surgeon's technical performance influences long-term survival for patients with colon cancer. And again, I think this is some of the first data that's starting to come out to show just how important our performance in the OR is. So what do you do when you get a measure like that and where you know that your surgical skill might be assessed based on a video-based assessment? And again, I think based on this conference, I'm certainly walking away knowing there's going to be more and more of that available. What do you do when you get that number, when you get that place that you might be in, knowing that it's related to how your patients are going to do? How do you improve? And I think that's, again, where video can be really, really important, because not only can you assess your performance, but you can use that video to identify areas that you want to improve, to set goals, to reflect on your practice, to make intentional adjustments with accountability, and then to go back and see how it influences your performance on some of those video-based assessments. So we have more and more tools that are helping us to accomplish these goals, right? So if we want to do video-based assessment and we want to do video-based improvement, and I would argue that those two need to go hand in hand. It's not helpful to do assessment without a way to improve. We need to be able to capture and share video. We need to be able to assess video and have validated ways that we can do that. But then we also have to have ways to mentor and coach and to work together on collaborative learning to improve what we do. And this is the study that, again, Oliver showed the framework that we used for this, and this was the outcomes that we showed, and this was that we were able to, for people who did participate in our Michigan video-based coaching program, we decreased operative time for sleeve gastrectomy by 14 minutes for surgeons who participated in the coaching, with no change for those who were our coaches or those who did not participate. So again, just showing that we can make changes, we can move outcomes based on these video-based assessments together. Now, I think there's a lot of different places where we can use routine video for education, and some of these overlap with clinical care. All of the stuff that we just talked about in terms of how we're going to improve clinical care are also meeting our requirements and our desire for continuing professional development. There is an incredible gap we have in terms of transitioning to practice after training, and I think video recording and analysis of video offers us a really unique opportunity to continue education at that point. It can be incredibly important as we're learning and adopting new skills and new technologies. I think that's still a little bit of the Wild West in terms of how we do that, and routine video recording can help us in that area. Oliver mentioned video-based morbidity and mortality. Again, I think that is incredibly important and a place that we really need to be moving towards. Having a video library available, right? Not only for our trainees, but also for our OR staff. So if you have a scrub tech who's gonna be scrubbing with you, who hasn't done a case with you before, wouldn't it be great if they could just spend 20 or 30 minutes looking at some of your previous cases to know how you do things, to know which instruments you tend to use to prepare? And then thinking about how we can use structured review as an adjunct to intraoperative teaching for our trainees. And we did a study in Boston where we looked at the type of teaching that happens in the OR and the type of teaching that happens when you use video for an assessment outside of the OR after the fact. And we saw that there was more teaching points per hour, with over 100 teaching points per hour if you were using video versus 63 in the operating room. The teaching was more resident-centered and goal-directed, which we know are important for adults as they're learning, and more complex concepts were able to be addressed. And just to show you a couple of points on this, if we looked at the teaching techniques that were used in the OR, almost everything was instructive. There was very little instructive interaction when we were looking at videos. But videos, you used much more questioning of the person that you were working with as the learner. There was also much more validating and much more goal setting in the video setting compared to when you were teaching in real time. Similarly, the content, as I mentioned, when we're in the OR, we're talking much more about anatomy. We're talking much more about progress, again, instruction. How do you move forward? When we're looking at video, we're able to concentrate on things that are a little bit more complicated, right? Failure to progress. Why aren't you moving forward in the case in a way that can be sometimes difficult or challenging to recognize in real time? And then looking at more complex concepts like intraoperative decision-making, situational awareness, and then again, doing that needs assessment so that you can figure out how to do goal-directed learning. Oliver mentioned this point about self-awareness and sort of that disconnect sometimes between how we view ourselves and how others view us in terms of our performance. And I think this study out of Toronto was a really important one where they looked at video-based coaching for a subset of their residents on their third-year rotation, whereas others just did the traditional training paradigm. And the ones that got coaching showed an improvement on OSAS and their other measures measures of their technical skill. But I think the more interesting and more important part of this study was that they looked at self-reflection and they looked at the correlation between how the trainee viewed their own skill compared to how a panel of experts viewed their skill, and found that there was no correlation at baseline for either the control or the surgical coaching group. But after they participated in surgical coaching, there was a strong correlation in how they rated themselves using OSATs and how they were rated by experts. So again, if you don't see yourself, if you're in a vacuum, you have no concept of how you are compared to other people. And so routine video and access to that can help you to really gain insights and to understand your limitations and your areas for improvement. And then finally, research. I think that this is an area where people are like, oh, is that research? How am I going to get funded? And this is just an example for our video-based coaching work. Some of the places that we were able to get funding, which included foundation funding, local funding, we were able to get 2 different R01s. And so there is a lot of funding, I think, that you can get in this. I think Carla Pugh is another example of someone who has a very well-funded federal program based on video analysis and video review. I think Oliver and his team in Michigan, another great example, people who are getting large federal grants to fund the ability to study video and to understand and improve performance. So in summary, I really think that video offers us a very unique opportunity to improve all of the different aspects, all of the different missions that we have within an academic surgery department. But it's not easy, and it requires a major culture shift. I think the biggest issue that we have right now is that this is not necessarily a part of our culture, and these are just a couple of the papers that we've published about how coaching can help us to move culture forward. It's a little bit of a chicken and the egg, right? We need culture change in order to implement routine video and routine video analysis, but routine video analysis and capture is also gonna push forward our culture change, right? So they're really intertwined. And so this culture shift that I'm talking about really moves from that big brother that Alex alluded to, job evaluation, peer of the unknown, right? That black box that I think every one of the speakers has talked about that the OR has traditionally been, to one that focuses on transparency, emphasis on patient safety, advancing technology, investing in technology. And I would argue that this middle column is probably where we are now. Right? We're recognizing the potential, we value transparency, but where we really need to get to is learning, team training, optimizing safety and performance, and constantly studying what we're doing at the point of care in the operating room. And I would argue that this is really important because it's gonna happen. This is going to happen. Somebody is going to enforce this if we do not take ownership and make this happen. So we as frontline providers and we as surgeons have to be the one to drive the development and implementation of video in the OR. We have a narrow window to get this right. It's up to us to make sure this is constructive, and I apologize for the typo and not punitive, that it's focused on formative evaluations and identifying areas for improvement, that summative evaluations are not used for high stakes until we know better what we're doing, if ever, that it's more of a baseline evaluation, a way to identify gaps, to set goals and to track improvement, and that we continue to do this in a rigorous way so that we continue to generate evidence to make sure that we're doing it right. And so with that, I'd just like to thank you for your attention. I look forward to the discussion.